Good morning, good afternoon, good evening, wherever you may be joining from. Welcome to this CBITN webinar series installment, this time on implementation science theories and frameworks to improve translation of research to practice. My name is Justin Pressot, and I'm joining you from the Ottawa Hospital Research Institute, where I direct the methodological and implementation research program. And just to situate you, if you're joining us from somewhere outside of Canada, I'm based in Ottawa, capital city of Canada, where we definitely experience 4 distinct seasons, with temperatures ranging from plus 30 down to easily minus 30 in the winter and plenty of snow. But if ever you find yourself in our midst and the topics that we're covering today are of interest, please do drop us a line. We're always keen to welcome visitors to our Center for Implementation Research here. Okay, so what I'm going to cover with you today is really a deep dive into models, theories, and frameworks. I'll cover why we should care about using them, cover different types, give you some key examples, and then we'll finish off with how you might think about approaching how to choose from amongst the many models, theories, and frameworks out there. But first, to set the scene, why do we care? Why is implementation important? Well, one of the reasons is that we're investing hundreds of billions of dollars per year in a range of biomedical and health research, including behavioral interventions. But despite that investment that has the potential to improve the health and well-being of citizens and patients worldwide, consistently what we find when we look at the clinical and health services literature is a failure to translate what the research evidence is showing is effective into routine practice and policy, which has led some to describe really our health research endeavors as all breakthrough, no follow-through. So consider a scenario that you might be thinking through going through the IBTN or CBITN summer school or this seminar series more generally. That maybe you've been co-developing a theory-informed behavioral intervention, you've chosen a clinically significant question, and you're hoping that it will change the behavior of patients and the general public so that it can improve their health and well-being. You've conducted a feasibility study, you've done maybe even a randomized pilot study, you've selected your design and RCT, identify core outcomes and processes, and you've even run a trial. And amazing, effective intervention, you've published widely, presented widely, and maybe even someone's done a systematic review showing 10 other teams have run a similar trial, with similar intervention, all pooled together with a pooled effect in favor of your intervention. Now, the question is, how will this intervention, despite its strong evidence, reach patients and the public? In other words, how will it be implemented in routine delivery in the health system if that's where it needs to land in order to reach patients and the public? People in the health system need to change what they do, might need to do more of something and or less of something. How do we ensure that that happens with respect to your particular intervention? So another way to think about this is we are, and you are, in the midst of developing these breakthroughs. But if we ignore implementation, that we risk developing rigorous trials of efficacious behavioral interventions that ultimately don't get used beyond the trials that are evaluating them. And that's why we should care, in my opinion, about implementation and where implementation science becomes relevant. Because implementation science is really, it's the science of the bridge between the discovery of what works and its impact on health and really on society. Or another way to think about it is the scientific study of the methods that we can use to promote the systematic uptake of research findings and other evidence-based practices into routine practice. The goal here is that we're trying to learn from each other. We're trying to develop a generalizable empirical basis for optimizing implementation activities to improve healthcare. And I find sometimes in a range of different disciplines, but implementation science is one of them, that sometimes non-jargon language can help us think things through when we're engaging in new processes. So When you think, and this is adapted from a really useful paper by Jeff Curran in Implementation Science Communications. So when we're thinking about the intervention, the practice, the innovation, in other words, your behavioral intervention, for example, that he calls the thing. And efficacy or effectiveness research looks at whether the thing, your behavior change intervention, actually works. Implementation research, on the other hand, looks at how best to help people and places do that thing. And we use implementation strategies as the stuff that we do to try to help people and places do that thing. Implementation barriers and enablers are what the strategies address to help people and places do that thing. And key implementation outcomes that we're interested in, how much and how well people and places do that thing. So why should we, hopefully that convinces you of the importance of implementation science per se, but why should we care about models, theories, and frameworks? The first point that I'll make, and I'll make it a few times in our conversation together today, is as much as the temptation is there, don't be lulled into the temptation of jumping straight to implementation solutions. And I'll try to make a case for why that is. Now, often that's where our mind goes, and there are some common strategies that we can gravitate towards often. Maybe if we're trying to change what healthcare providers do in the system, we might think about developing and issuing clinical practice guidelines, which are important, and there's an important endeavor behind that, but just issuing them doesn't mean they're going to implement themselves in practice. Other things might be needed. Another common strategy that we might gravitate towards is that we just try everything, throw everything at the issue and see what sticks. And when people have investigated that, seems to suggest that that is not the most useful solution, that more strategies doesn't necessarily equate to greater effect in change in the system. We might also gravitate towards our favorite solution, the one that we're most familiar with, for example, which it might work, but it might not. It might not be fit for purpose. And similarly, we might think, we need to deliver training or continuing professional development, or maybe even develop a digital solution. And maybe those are part of the solution, but those are very much methods of delivery. It's how we deliver strategies. But the question then becomes, what is the content that we should do to include in those CPD or digital solutions, and are they fit for purpose? But ultimately, jumping straight to solutions risks developing what's known as an islagiate intervention. And this is really just an acronym for it seemed like a good idea at the time. Frequently used approach to developing implementation strategies, for sure. And it has some major risks. So the risk is really, it's a potentially expensive version of trial and error, which isn't to put down trial and error approaches. It just, there may be quicker, more evidenced approaches to getting to strategies and solutions. And because of that, islagiate can lead to the risk of at least inefficiencies by not building on what we already know, by creating insufficiencies, by may miss strategies that could be more useful or more efficacious to address a given barrier enabler. It really relies on tacit instead of transferable knowledge, so it makes it difficult to learn across different settings and difficult to maintain learning when leadership changes or restructures. And ultimately undermines creating a cumulative evidence base so that different jurisdictions and different places can learn from each other instead of being faced with a whiteboard and a brainstorm at every situation. So if you buy into that argument, then ultimately we're faced with this situation that we have a traditional, it seemed like a good idea at the time approach, which is often characterized by someone sets a meeting with interested parties, we brainstorm solutions, someone decides on a solution, someone with gray hair, someone with less hair maybe takes the lead in making that decision. It gets implemented and we cross our fingers that it works. And don't get me wrong, it may work. It may indeed work, but it may not. And therein lies the value of implementation sciences. Before going to our solutions, trying to do where we can understand the issues, the problem in more depth, so that we can increase the likelihood that the solutions that we're developing fits the situation that we're in, and that we can learn from past efforts and contribute to future efforts through our application of implementation science principles. And that's where the models, theories, and frameworks really come in. So we'll talk now a little bit about types of models, theories, and frameworks. And increasingly, there's recognition of the value of using models, theories, and frameworks to draw from and build a cumulative evidence base. And Per Nilsson in 2015 wrote just a wonderful paper unpacking different types of MTFs, which he linked to different KT or implementation processes. And so he unpacked different MTFs in terms of either describing or guiding implementation processes, understanding or explaining what influences implementation outcomes, or evaluating implementation, and unpack different types of models. Now, before we dive into each of those, I want to take a minute to just make a stronger, higher level point about equity and intersectionality, which is increasingly being highlighted and integrated within implementation science more generally. But the point here to make is that experiences and identity that people have, whether they're patients in the public that are recipients of and partners in our interventions, our behavioral interventions, or indeed people working in the healthcare system delivering these interventions, their experiences and identity are shaped by a range of interacting factors. And often we're tempted to limit ourselves to, labels or a list of sociodemographic descriptions, often in a table 1 in our papers. But people are so much more than that list. They help to clarify people's identities and the intersections of those identities with systems of power and sometimes of oppression that can result in social hierarchies. And our models, theories, and frameworks are only starting to really integrate some of those conceptualizations on equity and intersectionality. And recent work that I've had the good fortune of being involved in is trying to adapt, or at least provide a lens to some of the models, theories, and frameworks, more common ones that we use, to take it into better account how we generate data and build up interventions to take these considerations into advisement. And if you're interested in that, there are a range of these papers that do a better, more deeper dive consideration of this. Okay, so we talked about these 3 different categories that Per Nilsson outlined. Models that are about models, theories, and frameworks that are about describing the process, models that are about understanding what influences outcomes, and models for evaluating. So process models, we'll start with, here's some of the classic ones. These are high-level descriptors that are models that describe steps that we might take to go through and implement research into action. 2 that I want to highlight here are the knowledge to action framework developed in Canada, as well as the French model internationally developed, and we'll talk about each of them in more detail. The second type are determinant framework, classic theories, and implementation theories, or KT theories. So a determinant framework, 2 that we'll cover today, theoretical domains framework, consolidated framework for implementation research, or CFIR. Classic theories that have been brought in from other disciplines and applied to an implementation setting include theories like the theory of planned behavior, social cognitive theory, control theory, health action process approach, that have been developed within a different context, a different discipline, but brought in to understand implementation processes. And then there are those implementation theories that have been generated from within implementation science since it has been established, things like normalization process theory or the theory of organizational readiness for change. Let's go back to that first process model of the knowledge to action framework. It's developed by Ian Graham almost 20 years ago. Helps to understand the distinction between moving from how we generate what we know might be effective, so that knowledge creation funnel in the middle. And this might be the process of actually developing your behavioral intervention, understanding what intervention, whether or not your intervention works to change behavior and improve outcomes for patients in the public. There might be some knowledge synthesis around that ultimately produces something to be implemented in the health system. And that's where implementation really starts, that outer ring, the action cycle that we move through a different set of processes. And so when we're talking about knowledge creation funnel, it starts off with that knowledge inquiry. In an individual study, usually is not enough to change or warrant practice or policy change, with a rare exception. But ultimately feeds into other studies that can be reviewed as part of a systematic review, ideally, and then produces something for that might be promoted for change in the health system, whether it's a guideline, a decision aid, a policy brief. But producing and publishing, disseminating, whilst they're all important, just doing that doesn't necessarily guarantee that people in the health system will actually take up your behavioral intervention that's shown to be efficacious. And as I say, and that's where the action cycle comes into play within this particular framework. And I'm going to focus the rest of today's webinar really on 4 key steps within that action cycle: the who needs to do what differently, when, where, and how, or identifying the no-do gap, identifying which factors determine whether or not they do or don't do that thing, barriers and enablers, then moving into strategies that can be used to target those factors, so selecting and tailoring interventions, and then how do we evaluate whether what we've developed actually works. And where we're drawing from, those 4 components are the French model that I described. The who needs to do what differently, what are the barriers to doing that, what strategies work, and how can change be measured and understood. So starting off with who needs to do what differently, ultimately, and arguably, fundamentally, what this means is also a behavioral issue. So you've been thinking about behavior and behavior change from the perspective of patients or members of the public that you're trying to support to change a health behavior in some of your behavioral interventions. But ultimately, when we're talking about implementation, it's also a behavioral issue, just different people at different levels. Often multiple people at multiple levels, but fundamentally people have to change what they're doing in order for them to implement into practice. So we're used to thinking about patients in the public, but in order to implement something into practice, it might involve families and friends, it might involve coworkers and teachers, it might involve physicians changing what they do, nurses changing what they do, public health officials, and even decision makers. All might have to change something in order to ensure that your intervention is being used in a routine practice in the healthcare system. And so if we take that approach of trying to use or to unpack what are the behaviors of those involved in the implementation process, one tool that you might find helpful is something called the ACT framework, which is just an acronym that stands for Action, Actor, Context, Target, and Time. And this is based off early work by Martin Fishbein, developed within the health psychology and behavioral medicine field to really set a foundation for understanding and measuring what is the behavior that we're trying to understand and change, their barriers and enablers, and possible strategies. And using this framework, often you can use this alongside knowledge users and interest holders to get on the same page about what are we trying to focus on here? Whose action, what is the action? Who's doing the behavior? In what setting? For whom? With whom? And over what time period? And how often? Often when we're talking about an implementation setting, it might mean more than one person or more than one behavior, and there are extensions to this particular framework for thinking through how behaviors are connected to one another, and how different actors might be responsible for those different actions in different contexts, targets, and time. So really this is a way of, first of all, getting on the same page about who needs to do what differently, and then trying to understand and pinpoint where there might be pinch points and barriers and enablers for each of those changes to happen, and putting in place strategies to mitigate those potential barriers. So once we've identified who needs to do what differently, the next step is to identify what are the barriers and enablers to address. And this is the area probably where a large majority of models, theories, and frameworks have been applied within implementation science, so it's worth kind of getting a sense of what are the main frameworks that have emerged within that space. Now, we're not short on models, theories, and frameworks. There are dozens that help in this space. But 2 that I wanted to really put an emphasis on are the Theoretical Domains Framework, or the TDF, and the Consolidated Framework for Implementation Research, or CFIR. Now, the TDF can focus on anyone at any level, whether it's patients, citizens, providers, policymakers. There's examples of studies on all those levels. And there's now hundreds of published TDF studies. So you can draw on other applications of the Theoretical Domains Framework potentially that have been applied to your specific action, actor, context, target, or time. The CFIR is itself more specifically focused on the perspective of the healthcare setting. There's some really good resources online at cfirguide.org that provide detailed descriptions on the framework itself. But both can be used in qualitative studies and surveys, and to unpack barriers in systematic reviews, for example. So to give you a bit more detail about the TDF, or Theoretical Domains Framework, it was developed as an attempt to synthesize decades of research in behavioral science about what do we know about modifiable factors that determine whether people do something, whether people engage in a behavior. And it's synthesized in its most recent version into 14 different domains on the left. It really provides, to my mind, a broad list of topics that you can explore that are known to affect behavior. A really useful guide to applying the TDF was published in 2017 by Lou Atkins and colleagues. And it's been used quite a lot to understand and unpack barriers and enablers to behavior change, as I say, across a number of different settings and actors and levels, using a range of different methods, whether it's interviews or focus groups, questionnaires, or metasyntheses. And one of its more useful characteristics is that it links directly to other models, theories, and frameworks, which we're going to talk about shortly when you get into selecting strategies, whether it's the behavior change wheel or behavior change techniques taxonomy. The other framework is the Consolidated Framework for Implementation Research, CFIR, as I mentioned. That was developed really with the same ethos as the TDF to synthesize common constructs published from implementation theories. And they identify 19 specific models, theories, and frameworks that might fit into this particular framework, and has been massively influential in implementation science and has been recently updated in 2022 based on responses to user feedback. And like the TDF, is an example of a framework that has been updated and that continues to be updated to reflect the evolving landscape of MTFs, and has been used and can be used to surface barriers and enablers in qualitative survey or systematic reviews, and really tries to situate the innovation that is being implemented, how individuals engage in implementation processes and the characteristics of each, and how that works within a particular setting, inner setting, the organization in which it's implemented, as well as the broader outer setting, the community and or geographic area or system in which that organization is integrated, and so provides that broader perspective of implementation. And so to think about each of those constructs in more detail, or those domains in more detail, you can think about the innovation as the thing being implemented, whether it's your behavioral intervention, a treatment, a program, a pathway, a service that happens within where that is being implemented. It could be a hospital, a school, a clinic. From the outer setting, which is the wider system, or the wider setting, hospital system, probably the country, like I mentioned. The individuals also have characteristics, roles in those settings, and then there are particular processes or strategies that can be used as part of supporting the implementation by individuals in their inner setting, within the outer setting of that innovation. And you can unpack each of these in more detail. I'm not going to do that here. But just to say that this provides a foundation for interrogating or understanding barriers and enablers for each of these domains. So when you're comparing the two, and again, these are just two of many models, theories, and frameworks, but they're among the more well-used, and so a good starting place to think about whether they might be useful for you. Both have similar purposes, synthesis purposes. Both have a scope of application that is often focused on understanding barriers and enablers, where the TDF really emphasizes behavior. It has to be about behavior. That's the goal of the TDF, is understanding behavior, whereas CFIR focuses specifically on healthcare settings, not necessarily the behavior per se, though it could. And both have links to other models, theories, and frameworks, whereas the TDF is based on psychology-based theories, models, and frameworks, and behavior change literature. CFIR is based on the health services and implementation theories, but both are linked to things like or a list of strategies. So, and we'll talk about each of those shortly. So that's who needs to do what differently, what are the barriers and enablers, then how do we then move to strategies to address barriers and enablers. And so this is where some definitions might be helpful. And so when we talk about an implementation intervention, that can include one or more implementation strategies or behavior change techniques. Or an implementation strategy is techniques or approaches designed to enhance a program or practice that's adopted, implemented, sustained, or scaled. A de-implementation strategy might be similarly techniques or approaches try to reduce or eliminate low-value, inappropriate, ineffective programs that might still be routinely done. Whereas a behavior change technique is the smallest part of content of a behavior change intervention that can be observed, replicable and in principle on their own, bring about behavior change. So these distinctions might be helpful as you're thinking through some of the terminology in this space. And I would say there's no, at least in my experience so far, there's not really a right strategy for all barriers and enablers, that a tailored approach might be your best bet and should be your best bet typically. That faced with specific barriers and enablers, it's best to try to select techniques best suited to address them if you're able to. And so the analogy here, and apologies if you're joining this webinar with as a vegetarian or a vegan, but I hope you'll allow this analogy that if you were cooking a rack of lamb, any number of possible herbs and spices could be used, some delicious, some not so much. Would you just open up your cupboard and mix as many possible ingredients as you can and hope that it tastes delicious? Probably not. Sometimes we do that with our interventions, but we shouldn't, in my opinion. Would we just make it up ourselves? We could do that, but that might involve lots of trial and error, especially if you're new to a particular implementation setting or context. And we could draw on what's already known. And in the cooking space, that amounts to cookbooks, but also training in developing skills in becoming a better chef or a cook, for example. And I'm not suggesting that what we should be trying to do is do cookbook-based implementation, intervention development. This is where my analogy falls down a bit, but that we don't have to start from scratch and just guess. Rather, there are existing tools and strategies to start to think through what might be better options for addressing key barriers, drawing what we already know. So to re-emphasize this point, where should we start? We should not start by jumping straight to solutions. We should start by identifying the barriers for the actors in the context and times that we're trying to change, identify the barriers that they might be facing, and then using the strategy or the approaches that I'm about to talk you through to try to select the right strategy for the particular barrier enabler. Now, there are probably at least three complementary approaches to selecting implementation strategies, developing implementation interventions. There's a framework-based approach, a model-based approach, and an evidence-based approach. And I want to reemphasize these should be seen as complementary rather than competing options, that they feed off each other. But I would probably say one of the more common ones is a framework-based approach. And this is the approach that draws from consolidated lists. And just as the CFER and the TDF were designed to synthesize what we know from the theories, models, and frameworks that can be used for barriers and enablers, a similar effort has been underway to synthesize strategies and or techniques. Recognizing that if we're trying to get on the same page and build an evidence base around implementation strategies, we need to get on the same page about what we're calling these things. Because there are situations, if we don't do that, we might be using the same term to mean different things, or different terms to mean the same thing. And how do you develop a common understanding if that's the issue that we're faced with? And so this has led to the emergence of some frameworks to try to get on the same page of labels, depending on the levels of interest. And we'll talk a bit about the ERIC taxonomy, the EPOC taxonomy, and the behavior change wheel and behavior change techniques taxonomy and ontology. So we'll start with the framework-based approach and thinking about how the CFER-based determinants could be matched using the ERIC taxonomy. So we talked about the different domains within CFER and the constructs within them. So the question is, okay, so which strategy could we choose if we happen to identify barriers at one of these, in one or more of these factors? Thankfully, some work has been done, led by Byron Powell and colleagues, to try to synthesize and refine a compilation of possible strategies that we can draw from. So you don't have to make this up on your own. People have done some of the hard work to identify and label implementation strategies and organize them into 9 different categories, exemplified here. So there are strategies that are used to evaluate and iterate. There are strategies for interactive assistance, for adapting and tailoring, for developing relationships with interest holders, for training and educating, for supporting, for changing infrastructure, and utilizing financial strategies, and changing infrastructure. See, these are in more detail. If you go to that particular paper, you can see the definitions and, the label, all these labels and definitions per se. But again, it provides a starting place for what might be possible. So you don't have to make this up to begin with, at least. So then the question is, okay, we've got these big lists. Well, what we could choose, what should we choose is the question. And again, thankfully, some people have started to do some work in this space. So there's been some work based on expert consensus strategies, trying to identify what are best bet strategies along the top, along the first column to address CFR related domains along the top. And so what this amounts to is dozens of people that have an expertise in implementation science providing a judgment on what might be a starting point to think about where might you focus your energies on. And this is just a subset. If you want more details, going to the cfrguide.org/choosing strategies is where you can get access to this more detail. So it's definitely based on expert consensus as an approach, but think about that as this is an opportunity to draw on some of the most expert people in thinking this through in the world as a starting point. The next level up will be actually mapping an evidence base to each of these cells. But for now, as you're trying to make decisions about if you're considering addressing for example, culture, you might be more likely to focus on assessing readiness and identify barriers and facilitators than other factors, for example. So that's the CFR to ERIC taxonomy approach. Second approach might be to, if you're interested in the more behavioral level, is mapping COM-B to the behavior change wheel. So we talked about, in this approach, implementation being about behavior, someone at some level having to change what they do, and unpacking what those behaviors and actors might be. So one model that you may have come across to identify this at a higher level is understanding the capability, motivation, and or opportunity underlying a particular behavior, or COM-B. And this is the foundation for the behavior change wheel. Now, what the behavior change wheel also identifies neatly is a set of implementation or intervention functions, otherwise high-level categories of implementation strategies that could be used to address different types of capability, opportunity, and motivation. And that's clarified in the behavior change wheel publications. Again, as a useful starting point to think about if you're interested in psychological capability, focus on education and training and not so much on persuasion or coercion, clearly. And in a similar vein, what the behavior change wheel as a model theory and framework also provides rather uniquely is a set of policy levers or categories that can be used to support the delivery of those intervention functions. And so if you're interested in leveraging education, for example, communication and marketing and guidelines might be policy categories to consider, and there might be other policy categories that might be less relevant for a given intervention function in the behavior change wheel. Again, as a useful starting point to guide how you might build up your implementation intervention. A third framework-based approach is if you want to go more nitty-gritty than the COM-B and the behavior change wheel, you can go down to the theoretical domains framework and behavior change techniques and behavior change ontology level. And so a way to think about this is, if you're familiar with the COM-B, the capability, opportunity, motivation model, really the theoretical domains framework is a deep dive into each of those particular domains. And so they speak to each other, so to speak, in terms of models, theories, and frameworks. So if you want that nuance, you can get at that within the TDF, and that links up to the COM-B. But what that nuance adds at the TDF level is that you can get into more specific behavior change techniques that could be leveraged to address each of the barriers at the TDF level. And so just as for the ERIC taxonomy that brought together and tried to synthesize what are core techniques, in the case of ERIC implementation strategies, in this case behavior change techniques, how can we identify and label and define behavior change techniques? The behavior change techniques taxonomy version 1 was the first attempt to really bring together that in quite a lot of detail. So for example, with this periodic table version of the of this taxonomy. You can look at feedback and monitoring category, and feedback on behavior has a particular definition, whether it's what it is and what it isn't, so that it can be provided as a foundation or a way to describe a particular behavior change technique. So you might be asking yourself, okay, I'm familiar with the behavior change techniques taxonomy. We apply that often to describe our behavior change intervention. How does this apply to implementation? Well, if you bought into the idea that ultimately implementation is about changing what people do at different levels, then that's how it applies. It applies not just to health behaviors, but ultimately to people at multiple levels. And through a range of different pieces of work, we've shown that to be just indeed the case. So this is an example led by Jake Crawshaw that unpacked the behavior change techniques that were within interventions designed to change professional practice using audit and feedback. So audit and feedback is one ERIC strategy, and what Jake and team did was unpack all the behavior change techniques in interventions that were trialed using the audit and feedback, showing that there's a range of BCTs that can be identified. And we've done similar things within, for example, continuing professional development for healthcare providers, that you can unpack the behavior change techniques within those. And similarly, if you're trying to identify active ingredients within implementation interventions for diabetes, we've also shown you can identify the behavior change techniques that are designed to try to change professional practice in those spaces too. So this taxonomy applies just as well to the behaviors of people in the health system as well. And just as for the CFIR to ERIC matching exercise, there's been a lot of effort to try to link the behavior change techniques taxonomy to TDF domains. So, and again, this is a combination of evidence and expert consensus, and an evolving effort to try to make those linkages. And so if you're starting off and you've identified intention or goals as a key barrier or enabler, you can use this as a foundation for getting a sense of where are there agreed links or non-links or inconclusive links or no evidence for any behavior change technique in the behavior change technique taxonomy. There's also an additional framework that is worth considering as you're identifying those implementation interventions or their implementation interventions and strategies, is to consider the appease criteria, so that, and this stems from the behavior change wheel specifically, but I think could be applied really to any implementation intervention, is to just think about, as you're working with interest holders and developing your intervention, just think about how affordable is this, how practical, how effective is it likely to be, or cost effective, will it be acceptable, might there be side effects to consider, and what might be equity considerations that could be built into considering selecting your strategy, so that it's not only about the theoretical connections between them, but these factors too. And in my mind, importantly, it's not only about the strategy. So when we think about, there are reporting guidelines like the template for intervention, description, or application, or TIDIR, that recommend outlining any intervention in these more specific items. And that when we get to the what procedures, that's really the behavior change techniques or BCW level. This is the strategies, the active ingredients. But if you're interested in the who provided, or the how provided, or the where provided, there are emerging ontologies that are being developed for behavior change techniques as well, by the way. But if you're interested in the who, the how, the where, and some others as well, that there are specific lists, linked lists, that can help to unpack these again, so that you don't have to come up with labels or descriptions, that some of this work has been done, and it helps to then create a more cumulative evidence base in selecting the consistent labels across studies. It promotes transparency, consistency, and searchability. So that was framework-based strategy selection approaches. I also want to talk about model-based strategy selection processes for a second. So we talked about the TDF and CFIR, these compendium big frameworks that build on a foundation of specific theoretical models. But I would pose to you that those specific theoretical models may still hold value. That you don't have to necessarily jump straight to the TDF or CFIR, because those theoretical models often have decades, in some cases, of research underpinning their use and utility. And importantly, some of those theories actually suggest the right strategies to select to address particular barriers in their models, and describe how those strategies work, or the mechanism of action, which in your case may or may not be helpful. And this applies to implementation intervention. So here's an example of some work that I was involved in a little while ago that sought to understand 6 different clinical behaviors in primary care around in diabetes, around blood pressure prescribing for blood glucose, weight management advice, self-management, education, and foot examination attendance, or promoting foot examination, I should say. And rather than the TDF approach or CFIR approach, we selected specific existing theoretical theories of behavior and behavior change, and measured constructs from within them to ultimately build up a combined theoretical model to try to understand across these 6 different clinical behaviors what are the factors that help us to understand whether clinicians want to and actually do engage in these evidenced activities. And the useful part of this, in my mind, was also that because these theories have embedded behavior change techniques that helped us to identify if we can show that those factors are correlated, we then identified behavior change techniques for addressing each of those factors. So if we take self-efficacy as the classic one, which we showed to be associated with intention and behavior, that the 4 classic strategies for promoting self-efficacy then become the obvious first pass options for developing our implementation intervention with trying to change primary care physicians and nurses' practices. So we've talked about frameworks, we've talked about theory, model. What about evidence? And again, these are meant to be complementary, but let's think about the evidence-informed approach. Mostly because most of the linkage work that I've outlined in selecting strategies is based on careful consensus approaches. And in principle, they can draw more from evidence in my mind, and I think that's very much where those mapping exercises are going. But in the meantime, there are existing pieces of evidence that we can draw from in helping to build up our implementation interventions. And so one that I really wanted to emphasize is a specialty group within Cochrane, the Cochrane collaboration, that focuses on systematic reviews and interventions that are specifically about changing professional practice and how healthcare is delivered. And right now there's 184 of those reviews that are available in the Cochrane EPOC database, and so there's, it is definitely worth having a look at those reviews to look at what's available. And what's neat about the EPOC group is that they develop a taxonomy of strategies to support reviewers or authors of these EPOC reviews to categorize what they were reviewing, which ended up developing its own taxonomy of implementation strategies effectively. So these are 4 different areas of strategies that have been identified: delivery arrangement, governance, finance, but then I'll deep dive really in the implementation strategies bucket there. And again, I won't put too much emphasis on this for the sake of time, but you can go to epoc.cochrane.org/epoc taxonomy to really get a deep dive list of the labels and definitions for each of the implementation interventions that they've outlined, and many of which actually have Cochrane reviews linked to them. And for my money, that's what makes this taxonomy really a unicorn amongst existing strategy lists, is that it's inherently tied to implementation strategy evidence. So that if you're interested in audit and feedback, for example, look to the Cochrane review on audit and feedback to see what do we know about that as an evidence base. And so here's a selection of trials of implementation strategies that are in EPOC reviews. And this is what I should emphasize as well, is that for many of these Cochrane reviews, what they're doing is they're synthesizing or reviewing randomized or cluster randomized trials where clinicians or settings are randomized to receive an implementation intervention or not, and then checking to see if that changes practice. And so they've tested things like sending printed educational materials or reminders, or audit and feedback, educational meetings, using outreach visits, local opinion leaders. In some cases, there's dozens, if not hundreds, of these trials evaluating if these strategies work to change professional practice. And so you can draw on that as a basis to complement your selection of strategies in your implementation intervention. So we talked about who needs to do what differently, what are the barriers and enablers, what are strategies, how do we then check to see if all this worked. And a way to think about this is that we might on the left have our implementation intervention that includes strategies or techniques to address the barriers we've identified. And ultimately we want to see, does that implementation change practice in the far right? Does it lead to more adoption, penetration, sustainment, and reach? But you can also measure the process of that. Does the implementation intervention affect implementation the way that we think? And that's the value of some of the theory-informed list of barriers that we've used. Can we show that when physicians or nurses or whomever receive the implementation strategy, it changes the barriers that we're trying to target? So a couple of models, theories, and frameworks to run you through at that evaluation side. One that you might have come across already is the RE-AIM framework, which is another acronym that stands for reach, efficacy or effectiveness, adoption, implementation, or maintenance. And the way to think about this is reach and effectiveness typically is a focus and a function of patients and members of the public, the people to whom the ultimate intervention is directed. Adoption implementation tends to focus on the people working in the healthcare system, so the types of interventions we've been talking about today. And then maintenance could be both. And I would encourage you to look at reaim.org for even more detail on applying this really useful framework. Apologies for that. I may have gone too far ahead. The next piece is process evaluation, which addresses the why and the how. And so we have theory-based process evaluations that can provide a way of testing whether a change in practice is explained by the theoretical constructs that are targeted by the implementation intervention, so the mechanism of change, or whether the implementation techniques or strategies were delivered or received as designed with fidelity. So I'm going to focus more on the mechanism of change, but this is really where you can draw from the MTFs that you've used specifically. And increasingly this is being done, so this is a review from a couple of years ago now by Steve McIntyre and colleagues that looked for how theory is being used in process evaluations in implementation interventions, and showed that many cite, not very many use, but there's increasing opportunities for doing that in more substantive ways. And a way to do that, for example, is to think you might have, before your implementation intervention, you might design a survey or theory-based questionnaire that your intervention group physicians or your control group physicians fill out. They're randomized, or they receive an implementation intervention or not, and then you check again, same theory-based questionnaire to see whether those in the intervention group change their scores in the barrier assessment based on theory, to try to explain whether or not that explains any change in practice. And we have a couple of examples here of doing that exact process of having a randomized or cluster randomized trial evaluating an implementation intervention, and a process evaluation alongside, using survey-based approaches or mixed method approaches in some cases to understand, can we explain why the implementation intervention worked or not using these processes. Another evaluation framework that can be used at multiple steps of the process is one that I quite like, the theoretical framework of acceptability. This is work by Mandy Sekon that really recognized that often we're interested in the acceptability of any intervention, including implementation interventions, but there are many ways to define that, and they did some really nice work to synthesize different ways of conceptualizing acceptability. And once they had done that, started to develop a theory-informed questionnaire to help assess acceptability. It's a relatively short questionnaire that can be used as a way to look at how people feel about an intervention, whether the amount of effort that's required is worth it, whether it fits with their value system, if they understand how it works, what are opportunity costs, whether they think it'll work, and how they feel confidence in whether they can engage in the behaviors needed. And that can be done prospectively, concurrently, or retrospectively, so a really useful framework for understanding acceptability. Another model theory and framework to flag you towards is normalization process theory, which again could be used to inform intervention development, but also has often been used in a process evaluation alongside implementing interventions. And this is an action theory that emerged from medical sociology in particular, but also within implementation science generally, to understand how new technologies or interventions become integrated routinely into healthcare. In other words, the work that people have to do in their healthcare jobs to make this part of the background, this new practice. And they've identified a range of specific constructs to characterize how that normalization process occurs, and has often been used in using qualitative methods to elicit views that are consistent with NPT constructs. But there's more recently also been some work to develop a survey called the NOMAD tool, led by Tracy Finch, that can be used as a way to assess at different time points during the implementation process where respondents are at in terms of the normalization of a given use of a given intervention. Okay, so we've talked about who needs to do what differently, what are barriers and enablers, what are strategies to address them, and how do we evaluate that change. We've talked a lot about different models, theories, and frameworks more generally, but you might be asking yourself, okay, great, how do we choose from amongst all these different options? We've got lists within scoping reviews. There's databases and tools that kind of outline it. Still faced with how do we choose, but at least these provide the options from which to choose from, so you're going in with clear perspectives. But we work to try to develop a tool, and this is led by work by Sarah Birkin and colleagues, to try to identify what are factors that you can think about when comparing models, theories, or frameworks to one another, and maybe even to justify the one that you select from. And so this is based on some work that we did that asked over 100 implementation researchers from around the world on what are the models, theories, and frameworks they use and how did they decide on using it, and then bringing together what are some of the key factors to consider, which can be summarized as usability, testability, acceptability, and applicability. And so as you're considering yourself whether to choose one or more models, theories, and framework, it might be useful to work your way through each of these considerations to justify whether or not it's the right fit for the work that you want to do. Which leads me to my final slide that are in terms of a take-home message that I hope that what over the course of this this virtual conversation that we've had today, what I hope that you can take home is that frameworks and theory help us to avoid some of the risks of it seemed like a good idea at the time. It helps us to draw on what we know from other places and spaces instead of reinventing the wheel. Helps to promote a shared language and operationalization, helps to provide direct suggestions for techniques to address particular barriers, and might propose novel ideas for intervention that you might not have thought of, but that inspire that novelty by looking at what's possible. It's really important to pin down who needs to do what differently, and then before jumping straight to solutions, identifying the barriers that could then be targeted, because otherwise we risk developing solutions that are elegant, time-consuming, but actually don't address the right problem or might be the wrong solution. And increasingly there are these emerging tools that link these compendium frameworks of barriers and enablers to possible strategies that are purpose-built for addressing a given barrier and enabler that I definitely point you towards as a basis for thinking through how you might select your own implementation strategies and develop your implementation interventions. So that just leaves me to thank you for your time this morning, this afternoon, or this evening, whenever you're watching this. And of course, if any of this is of interest and you'd like to connect, never hesitate to reach out to me at any point. Thanks very much for your attention and have a great day.